Bismillah ar-Rahman ar-Rahim. Hi dear third year medical students, we will talk today about nutritional status assessment. Why it is important? Because many diseases occur because of imbalance between the nutritional state and the nutritional state of the patient, whether it is arranged with a normal body requirement or supply, or it is deficient. So as we said, imbalance between the requirement and the supply of this nutrient and substrate of metabolism, this result in a nutritional disorder. So the risk of complication can be minimized and the loss even prevented or may be preserved or reversed by a nutritional therapy. Now, what is the nutritional assessment? Nutritional assessment is improved. It is a way to evaluate the nutritional status of the patient or a person, and it is essential for diagnosis of different disease because, as we said, it is the imbalance between the need and the supplement of nutritional supplement to maintain normal life. And here it is important, as we said, for the diagnosis to prevent or even treat the acute or chronic disease if it occurs. So the evaluation of nutritional status, including as other medical diseases, it includes taking the history, physical examination, and lab investigation. So to provide diagnosis, we have to include the nutritional assessment, should include anthropometric measurement, clinical evaluation, lab assessment, and dietary evaluation. So this is the answer for the nutritional assessment. All of these four together, not only one of them, because it can give an idea, but it is not a complete diagnostic way. And none of these techniques or any single technique is enough to diagnose a nutritional status. So anthropometric measurement, what do we mean? It is simple and it is a most quantitative measurement of nutritional state. It can measure the body thickness and estimate fat and lean tissue mass. Why we use this anthropometric measurement? Use it to monitor normal growth and to detect nutritional health in a well-nourished individual, and also detect the nutritional inadequacy or excess in a malnourished patient. So the advantage of anthropometric measures, it is simple, it is inexpensive, it is cheap way, it is safe, and can be applied at bedside, so it is applicable. But the limitation here, it can only detect the nutrient abnormalities that result in a measurable change in body size or proportion. So it is a diagnosis of at late stage, way for diagnosis of late stage nutritional disease. Now the measured are the weight and the length in infant. Those who are less than 3 years, we use the length and or the height for those above 3 years. And we can use the head circumference mainly in infant and young children, triceps, skin fold thickness, and subscapular skin fold thickness, and mid-upper arm circumference. So regarding body weight, it is simple, convenient, and useful indicator for nutritional status. And the offspring of a malnourished mother or poorly nourished mother, also they have low birth weight. They born with a very low birth weight, and the child here is at great risk for many diseases because of decreasing weight for his age. And the weight should be measured by using a lever balance type scale like this one. This is optimal scaling, and we have other scales, automatic and different scales, hanging one, and so on. So the reference table, we have to provide standard weight according to the reference table, and we have to compare the result of the person or a patient with the standard table. Also, it is based on the height, on the age, and sex. There are different tables according to sex, to the gender. If the patient has edema at the time of weighing, the weight may be falsely high because of edema. So we have to be careful when we weigh the patient with edema, it is a false weight. What about the length or height? As we said, in infant and toddler, the length is measured in supine position with a fixed headboard like this one. We have to put the patient on supine position, and this part is fixed, the head part, and we just move the lower part It is horizontal movement and measured using this horizontal arm, and which can move vertically on calibrated vertically. Here in this patient we have to use it. If the patient is more than 3 years of old, we use this vertical, as we said, vertical arm. The leg here is fixed and we can move this part up and down on this scaled and calibrated scale, while for a young patient the upper part of the head is fixed and we can move this part at the inside or at the leg side. The patient should be without shoes, heels together and against a straight surface with a head level erect and about 3 years of age. Now, skin fold thickness consists of 2 layers of subcutaneous fat without muscle or tendon. It can be measured by a special caliber. We call it the Lange skin fold thickness caliber. And the skin fold thickness measured for forceps, biceps, subcapsular and suprapubic regions can be measured. We have here a fold of skin in the posterior aspect of a non-dominant arm midway between the shoulder and elbow. Is grasped gently and pulled away from the underlying muscle. Average of 3 reading taken and compared to reference standard table to assess the fat thickness. So we have to take this from this caliber and we have to check the skin fold thickness, as we said, in the posterior part of the arm, and we may check in the area between, in the midway between the shoulder and elbow. We have to check the midway and we have to grasp gently and assess the reading, and we have to repeat the reading 3 times to have the proper reading. It is different according to age and also according to sex or gender and ethnic group. So in male, if it is less than 12.5 millimeter, there is undernutrition, and if it is more than 20 millimeter, there is overnutrition. In female, if it is less than 16.5, there is undernutrition, and if it is more than 25, there is overnutrition. Head circumference is also, this is a good index of brain growth, usually for infant and children, and it can be used for screening test for evaluation of microcephaly or macrocephaly, which is it is a standard procedure in pediatric practice. It is very important to assess the growth of the brain. Mid-arm circumference, it is important also, and it is as we said, it is a general index of nutritional status. It reflects both caloric adequacy and the muscle mass. So the mid-arm circumference measured at the midpoint of the left upper by the fiberglass flexible tape. There is a tape, we can use it, and we have to take also the mid-arm between the shoulder and the elbow, and we have to check to grasp it, and we have to check the mid-arm circumference. Also, in case of protein energy malnutrition, there is negative nitrogen balance, there is muscle wasting. Also, all the time we can detect whenever there is protein energy malnutrition, as the muscle mass is wasted and decreased, so there is decreased muscle or mid-arm circumference. The clinical evaluation here. Whenever there is malnutrition, it can result from either primary causes, as there is deficiency of intake because of dietary history and dietary deficiency, and second, it is secondary to some defect in the nutrient utilization, like patient with a GIT disorder, malabsorption disease, and others. So prolonged malnutrition, they cause following sequence of event. First of all, generally there is a decrease in tissue level of deficient nutrient, and there is a biochemical lesion that altered activity of enzyme dependent on a specific nutrient causes accumulation of its metabolite by time. So as there is deficient nutrient and it affect on the enzyme, it will act here accumulation of this metabolite by time, because it affects the enzyme. Some enzymes depend on that specific nutrient and its activity will be eliminated or decreased, so that's lead to accumulation of other metabolite. By time there is anatomical lesion, and finally there is cellular disease. Many of the clinical signs and symptoms of malnutrition appear later. mainly weeks or months after the initiation of that nutrient deficiency. Sometimes it is subclinical or even marginal malnutrition, but still the clinical examination provides overall impression of nutritional health. Medical history like chronic diseases, history of weight loss or even weight gain, a physician can detect a nutritional problem or assess the possibility of developing nutritional defect in the future, as in if there is a strong family history of heart disease, or we have to check the lipid profile because cholesterol mainly high in patient with in family with the recurrent or with a history of heart disease. And we have encouraged the patient to decrease the body weight. So sometimes hyperlipidemia is familiar and it causes heart diseases. And the earliest sign is obesity or overweight. So this is one of the medical history importance. Also physical examination. The physician looks for physical sign and symptom, not from other. We have to check thoroughly, and also we have to check from a nutritional point of view. This requires information of biochemical confirmation, by biochemical tests and by dietary data. First of all, remember that zinc deficiency causes abnormal taste. This abnormality in taste is seen also in taking medication or with the smoking, and the sensation of taste decreases even with increasing age. And dermatitis, might see dermatitis in patients with malnutrition. This dermatitis have many etiology, maybe due to zinc deficiency, due to vitamin A deficiency, vitamin E deficiency, vitamin B deficiency, and so on. And if there is edema, especially in the lower limbs, usually it is related to either protein deficiency or vitamin B1 deficiency. Also, we have to look for obesity. If there is obesity, overweight, or wasting of muscles, or there is apathy, these are irritability, these are related in nutritional deficiency symptoms. Special attention given to the area where signs of nutritional deficiency appear, like the hair. We have to look to the hair. If there is vitamin deficiency, it will be silky, hairy, it is thin, easily applicable, and brittle. So, and even the color, it is red color, silky like, very fine. And we have to look to the eyes. As the eyes, there is pitote spot as in vitamin A deficiency, or there is zero ophthalmia, or sometimes it is just there is night blindness. The mouth for cheilosis, for angular stomatitis, and mucous membrane, and the tongue as well. The teeth, there is dental caries, and thyroid gland. We have to check for evidence of hypothyroidism and or hyperthyroidism, and the skin manifestation, hypopigmentation or hyperpigmentation, folded exfoliation in the skin. And we have to check the skeleton for evidence of rickets in early age in the first 5 years of life, or may have osteomalacia or osteoporotic later in life. And tender reflexes, it is defective in malnutrition, as in cases of hypothyroidism there is a slow relaxation pace of reflexes. Neuromuscular excitability provide a clue for the presence or absence of nutritional defect. And as in case of hypocalcemia, there is an increase in neuromuscular excitability. Laboratory assessment also is important. It can identify specific nutritional related abnormalities. For example, anemia. Anemia can be detected by checking hemoglobin level and the BCV level. Iron deficiency also, it is important because many of the anemic patients, they have iron deficiency anemia. Protein deficiency, it can be estimated by checking serum protein level and other biochemical tests. And here it provides the first indication of a nutritional abnormality before even clinical and anthropometric changes occur. So lab investigation is important, mainly in early stages. If marasmic or marasmus patient appear, there is calorie deprivation and they have normal serum protein. But patient with a kwashiorkor, there is a protein deprivation and they have decreased serum protein with a normal activity. Okay. And dietary assessment describe the dietary intake background. This will help explain any observed clinical or biochemical abnormality. So 24-hour recall is not important. It is one of the most common method of dietary assessment, but it is not common, not advantages. It carries a disadvantage. The advantage is it is easy and require little effort from the patient to remember or to recall the intake. While it is disadvantage because it is the consumption in the single 24-hour period may be not representative of the current weekly or monthly intake. It doesn't give an idea about the food taken through the last month or the last week. And it is inaccurate data due to faulty memory. Sometimes the person cannot remember what he takes back through the last week or the last month. And even there is a quantitative error in assessing how much has been eaten. So 1 week dietary record for all food and beverages ingested recorded with approximate quantity and actual time of consumption is more beneficial, but it is hard to collect and hard to remember. Advantages, it is more accurate as we said and used for consumption pattern, which allow the medical professional to identify deficiency, and imbalances or excess of nutrient intake is well identified. Thank you.